Hi, my name is Joel Musa. I'm an anesthesiology resident at Vanderbilt University School of Medicine. We're going to continue our discussion of ECGs, and this is part 2 of a two-part ECG lecture. The goals and objectives continue from the previous presentation where we defined a normal electrocardiogram and understood how it relates to the beating heart. We're going to learn how to continue to distinguish between normal and abnormal ECG findings and essentially describe what we can do about these abnormal findings when we find a patient experiencing these under anesthesia.
Let's discuss one of the metabolic abnormalities that may be discovered once a patient is connected to ECG monitoring in the operating room. On the left, we see a normal ECG tracing, and on the right, we see an ECG tracing with a characteristic tented T wave. Patients who have a potassium level of 6.5 to 8 milliequivalents per liter may present with this tented T wave characteristic of hyperkalemia. Patients who are presenting with trauma with crush injury, as well as patients with renal dysfunction who have hyperkalemia, may manifest tented T waves on their ECG. Treatment for hyperkalemia is targeted at initially reducing the concentration of potassium in the blood. Here is an example of a 12-lead electrocardiogram of a patient who has hyperkalemia. Hyperkalemia is usually discernible in the V leads, and in this patient, he has tented T waves in lead V3, V4, and V5, which are abnormal and indicative of his hyperkalemia. As discussed in the previous slide, the level of hyperkalemia may be anywhere from 6.5 to 8 milliequivalents per liter. Here is an example of another 12-lead electrocardiogram of a patient with hyperkalemia. Again, you see tented T waves in this patient's V leads starting in V3, V4, and V5.
Hyperkalemia, once discovered, should be treated promptly to prevent the progression to life-threatening arrhythmias. Initial treatment involves stabilization of the heart by providing calcium, which prevents the hyperkalemia from causing life-threatening arrhythmias. Driving the potassium from the blood into the cell is accomplished by administration of beta agonists such as albuterol, as well as administration of insulin and glucose. If the patient is still able to make urine and does not have renal failure, administration of a diuretic such as furosemide aids in the elimination of the potassium from the blood. Failure to treat hyperkalemia once discovered can cause cardiac arrest and ultimately lead to death. Some patients may manifest supraventricular tachycardia, which is usually present when the heart rate exceeds 150 beats per minute, as is demonstrated in this ECG tracing here on the right, where the heart rate is approximately 150 beats per minute. Importantly, each QRS complex is preceded by a P wave. If a patient is stable, meaning that they are mentating or they have a normal blood pressure, attempt to reduce this heart rate by carotid massage or vagal maneuvers such as a Valsalva may terminate this supraventricular tachycardia. If these fail, providing adenosine, which terminates this supraventricular tachycardia, may be attempted. If the patient is unstable, meaning they're manifesting hypotension or the patient becomes unresponsive, they require immediate synchronized cardioversion or shock to terminate this supraventricular tachycardia.
Here is an example of a 12-lead electrocardiogram of a patient in supraventricular tachycardia. As discussed before, each QRS complex is usually preceded by a P wave. These P waves may be hard to discern due to the patient's heart rate. However, each QRS complex is narrow, confirming the diagnosis that this is indeed supraventricular tachycardia. Here's another example of a 12-lead electrocardiogram of a patient in supraventricular tachycardia. As discussed previously, P waves may be difficult to discern in these patients. However, on examination of multiple leads, you may be able to distinguish a P wave that may precede each QRS, as seen here in lead 1. As discussed previously, the rate is usually in excess of 150 beats per minute, and the complexes are narrow, as seen here. This confirms the diagnosis that the patient does indeed have a supraventricular tachycardia.
Atrial fibrillation is a rhythm that may be discovered acutely when a patient is connected to ECG monitoring. Atrial fibrillation, unlike normal sinus rhythm, is characterized by an irregular QRS complex associated with numerous P waves. If acute in onset and unstable, electric cardioversion is indicated, or shock. If chronic and in a patient who is poorly medically managed, rate control is indicated with a beta blocker such as metoprolol or esmolol. Alternatively, a calcium channel blocker such as diltiazem or verapamil may be used. Chemical cardioversion can also be achieved with an antiarrhythmic such as amiodarone, and in the acute setting, 150 milligrams administered over 10 minutes may be effective.
Here is a 12-lead electrocardiogram of a patient presenting with atrial fibrillation. As discussed previously, this rhythm is classically irregular QRS complexes with P waves being conducted irregularly. An examination of this rhythm strip, we see that there are P waves indeed. However, the QRS complexes are irregular, meaning they don't have a discernible, consistent rhythm. Here's another example of a 12-lead electrocardiogram of a patient presenting with atrial fibrillation. As discussed previously, this rhythm is irregular with P waves being conducted irregularly. An examination of this patient's rhythm strip, we do see P waves at the baseline. However, these are conducted in an irregular fashion, with the QRSs marching out in an irregular rhythm, characteristic of atrial fibrillation.
Ventricular tachycardia and ventricular fibrillation are two dangerous rhythms that may manifest themselves in the perioperative period. When compared to a normal ECG tracing such as the one on the left, ventricular tachycardia is characterized by wide complexes that bear no semblance to the normal ECG tracing on the left. If left untreated, ventricular tachycardia will progress to ventricular fibrillation, which is a non-perfusing rhythm. Both of these rhythms, ventricular tachycardia and ventricular fibrillation, should be addressed immediately.
Stable ventricular tachycardia, that means ventricular tachycardia where the patient maintains his blood pressure, may be treated by infusing amiodarone 150 milligrams over 10 minutes. Ventricular fibrillation, however, should be addressed by immediate defibrillation and CPR. Determination of the underlying cause of these two rhythms, ventricular tachycardia and ventricular fibrillation, should be carried out while resuscitation is underway. This means determining what the cause of these two rhythms, ventricular tachycardia and ventricular fibrillation, by determining what is called the H's and the T's, as will be discussed later in this presentation. Here is a 12-lead electrocardiogram of a patient presenting with ventricular tachycardia. As you can see, this patient has wide QRS complexes in all his leads. These complexes are irregular and monomorphic, meaning they have one shape or characteristic. This is characteristic of ventricular tachycardia. Here's another example of a patient presenting with both ventricular tachycardia and ventricular fibrillation, with the patient intermittently going into ventricular tachycardia interspersed by ventricular fibrillation. As discussed previously, ventricular tachycardia and ventricular fibrillation exist in a spectrum in which ventricular tachycardia, when left untreated, will lead to ventricular fibrillation. As mentioned previously, ventricular fibrillation is a non-perfusing rhythm and demands immediate defibrillation and CPR.
The H's and T's are important considerations in trying to understand why the patient is manifesting ventricular tachycardia or ventricular fibrillation. This includes hypoxemia, hyperkalemia, hypokalemia, acidosis, or hypovolemia. Thrombosis, toxins, tamponade, and tension pneumothorax represent the T's that should be considered in trying to understand why the patient has developed ventricular tachycardia and ventricular fibrillation. These represent things that we can actually manage in trying to terminate these life-threatening rhythms. In summary, over the course of these 2 lectures, we've been able to describe how we obtain a normal electrocardiogram such as the one pictured here. We also learned a basic interpretation of the normal electrocardiogram. Farther than the normal electrocardiogram, we've described several findings that are abnormal in an electrocardiogram in a patient undergoing surgery or in the perioperative period, such as ST depression, ST elevation, and Q waves. We've also described findings that would be typical of hyperkalemia, supraventricular tachycardia, atrial fibrillation, ventricular tachycardia, and ventricular fibrillation. We also discussed in a very basic fashion how these abnormal electrocardiogram findings should be addressed. It should be said that these findings should be taken in the clinical context of the patient and with consideration of their underlying medical condition and the operation that they are undergoing.